So in the introduction, we talk about the insertive spirometry, which is a form of a respiratory therapy used to encourage deep breathing. It typically involves the use of a device that provides visual feedback and encourages patients to take slow, deep breaths to maximize lung inflation. The primary goal of insertive spirometry is to prevent or treat respiratory complications, particularly after surgery or during periods of prolonged bed rest. It also helps by improving the lung function, clearing secretion, and strengthening of the respiratory muscles. Ultimately, it helps by prevention of the respiratory complication such as atelectasis and pneumonia. So the goals of this study was to assess the efficacy of insertive spirometry to prevent the respiratory complication, establishment of protocols to prevent respiratory complication, optimization of protocols to encourage effective use of the insertive spirometry, evaluation of proper patient education as well as adherence, comparing insertive spirometry use with incidence of respiratory complication in the hospital setting. In terms of methods, a multi-pronged quality improvement initiative conducted from November 2023 to February 2024. PDSA cycles were planned and implemented as a continuation of this QI initiative. First, the patients with the insertive spirometry ordered were screened, which included floors 4 South, 5 South, and 6 South. Then 3 residents were interchangeably assigned to do bi-weekly room checks for the device presence in the room, patient education about the device, and also adherence to the use. So the goal was to correlate the device usage with respiratory complication in inpatient settings, subsequently increasing the usage of the device and compliance, which will lead to prevention and decreased incidence of post-op respiratory complications.
On 88 patients who had the incentive spirometer device ordered for them, only 82% had the incentive spirometer device in their room, and only 72% of them were educated on how to use it. 55% of our cohort of patients had respiratory cause as a reason of their admission, and 40% or 41% of the total had an infectious respiratory cause as a reason for admission. 16% of our patients developed a respiratory complication after admission. Of them, 86% had the incentive spirometer in their room and 14% did not. Of those who had the IS in their room, only 58% were educated on how to use it. Fishbone diagram has been drawn to further analyze factors influencing respiratory complication development and incentive spirometer use and ordering. And the EMR remained unclear on who's responsible on ordering the incentive spirometer, educating the patient, and monitoring its use. In most cases, it has been the nurses, the residents, or physician who ordered the incentive spirometer or the respiratory specialist. No automatic orders for incentive spirometer have been placed for patients who are at higher risk of aspiration, developing a respiratory complication, or are already with a respiratory complication on admission, for those who are bedbound or post-surgery. No automatic orders for speech pathology assessment for these patients as well. Multiple plethora of diseases and conditions affected the patient's use of the incentive spirometer. Patients who were demented or delirious could not remember how or when to use the device. Patients who are in severe pain post-surgery or are sedated. Those who were depressed, demotivated, or fatigued.
Initiative was developed between transitional year residents, nursing leadership, respiratory therapists, and QI leadership. Our targeted intervention involved the use of incentive spirometry by patients in the inpatient setting, as well as education on the correct usage. After implementation, it was found that the incentive spirometry orders and education showed a minor decrease in respiratory complication rates. Our intervention had a minor impact on decreasing the rate of respiratory complications It did also help us find that there needs to be a standardized procedure for who educates patients on incentive spirometry use. And in certain situations, there needs to be more standardized order sets for patients who are at high risk for aspiration events, as well as a standardized precaution and oral care set that should be initiated on all high risk patients.